Morning, everyone. Thank you for joining us in this grand run of Health for the World. I apologize in advance for my voice. Apparently, COVID is not planning to leave us. Today, I'm pleased to present our lecturer and our guest to you, Dr. Alvand Hassankhani. Dr. Hassankhani is assistant professor in radiology at UPenn. He has completed his training in diagnostic radiology at Northwell Health, Long Island Jewish Medical Center, followed by 2 fellowships in neuroradiology at Duke and MGH. He has published in prestigious journals of the field, and his area of interest is healthcare policy, spinal oncology, and head and neck education. He also roles as the team leader in Neuroradiology Network Practice Optimization Teams, or NPOT. In this grand round, Dr. Hassankhani will present a lecture entitled Imaging of HIV. During the lecture, please feel free to use Q&A chat box for questions, and we'll cover those at the end of the lecture. Without further ado, we will proceed with Dr. Hassankhani's talk. Good morning, Dr. Hassankhani. It's a pleasure meeting you.
Yeah, hello to everyone, and thank you very much for that kind invitation. I want to thank the organizer and my moderator for inviting me to speak. Let me start sharing my screen, and we can get started. I'm going to talk about the imaging manifestations of HIV. Do you see the screen?
Yeah.
Yeah, okay. Let me just... I just want to... Sorry, I just want to turn off the camera so I don't get much of a distraction.
Dr. Alvand, we see the normal screen. If you can turn on in the presenter. Yeah, thank you so much.
Okay. Well, once again, a warm welcome to everyone, and thank you for the invitation to speak. I'm going to talk about neuroimaging of HIV. Just let's start with some statistics and background in terms of where we stand. Good news is that overall there has been a decline in the rate of HIV infection, but we still, the latest statistics by UNAIDS at UNAIDS meeting shows that there are about 38 million people worldwide that are living with HIV. And this number keeps growing. We should take that as good news. Why? Because that shows that the treatment regimen that is available now, the antiretroviral medications are working, so people are living longer, and the number of mortalities is declining. So we are going to, so these people are living a little bit longer rather than fading away in the statistics and dropping in the statistics by dying. But at the same time, HIV is not an equal opportunity infection. There is a lot of regional variations. There's a lot of variations around the globe. For instance, the numbers may be rising in some areas of East Asia or Africa. Same in the United States. There is a fair amount of regional variations. There are some areas of the United States that the number of HIV infections are not in keeping with the rest of the country. For instance, in the South, there is some variations in number of cases that are being reported. And there's also a lot of variability in terms of the incidence of the disease in the suburbs versus inner cities. Currently, there are about 1.2 million people in the United States that are living with HIV. And the new diagnosis of HIV in the States is about 35,000 people, and about 5% of them are reported in children. If you look at the numbers overall, it's staggering. There are about 40 million people who have died of HIV. And this past year in 2021, 650,000 people died of HIV globally. So it's still with us, and it's still something that we have to sort of deal with and face on a day-to-day medicine and radiology as well. When I was trained, when I was in training, in my clinical training, it was in peak HIV infection. It was not uncommon to see young people coming repeatedly to the hospital in a sort of a very desperate situation. A lot of them were sort of isolated. And this picture by Therese Ferrer basically tells the story of HIV in 1990s and has been selected as one of the 100 most influential photographs by Time magazine. It's basically she profiled the life of a patient that was dying with HIV in complete isolation, and towards the end of his life, when the things were sort of pretty much when he was terminal, shows the desperate situation that families finally catching up with him and captures the moment. So this was something that we sort of saw on daily basis back in sort of late 80s or 90s, before the antiretroviral treatment became more and more available, and the efficacy of it was proven. Antiretroviral therapy basically have variable degree of mechanism. Just to briefly give you a little bit of history about the life cycle of the virus, just as a review quickly, we know that HIV is a retrovirus. It binds to the CD4 receptors of the T cells and incorporates its own viral elements into the nuclear DNA. And it can stay dormant for quite some time, and it results in depletion and killing of the T cells, and results in profound immunosuppression, T cell immunosuppression, and the host becomes very susceptible to many different type of opportunistic infections and atypical infections. Now we know that HIV itself is a neurotropic virus. About greater than 60% of patients with HIV have some sort of neurological complaints during their disease. And on autopsy studies, 80% of patients have some sort of involvement of the CNS by the virus itself. And about 10% of the patients present with neurological complaints as their first presentation. Now, when it comes to neuroimaging of HIV itself, HIV, direct infection of HIV can result in the various degree of these manifestations. A patient may come with mild degree, some sort of degree of neurocognitive disorder, to frank HIV encephalopathy. Opportunistic infections that we are going to be discussing are going to be those that are related to atypical microorganisms, toxoplasmosis being the most common CNS opportunistic infections. But during this talk, I'm also going to talk about different viral infections such as CMV as an opportunistic infection, CRYPTOCOCCOSIS, and neoplasms can happen in setting of HIV, for instance, capillary sarcomas. And this talk I'm going to emphasize on, focus on CNS lymphomas. We're going to talk a little bit about the complications of treatment, such as immune reconstitution syndrome. And if time allows, we're going to touch a little bit on pediatric AIDS and some vascular complications associated with HIV. So starting with HIV leukoencephalopathy, it's not considered to be an opportunistic infection. Is basically a direct CNS infection of the virus, infection of CNS by the virus itself. It's fairly common. A patient may present with progressive atrophy, some neurocognitive changes, perhaps memory impairment, and on imaging on a pathological specimen, there's basically progressive bilateral symmetric white matter abnormality. The symmetry and bilaterally is basically the key of this disease process. And on gross pathology, there may be premature atrophy, and on HNE, you may see diffuse loss of myelin with some degree of adjacent inflammatory changes, such as gliosis. There may be a microglial and giant cell activation. It doesn't affect, it's usually exclusive to white matter. It's rare for it to have any involvement of the cortex and deep brain nuclei. This was a 34-year-old man with cognitive changes as non-contrast CT. For age, there is fairly profound prominence of the ventricles and the cortical sulci. For the given age, there is fairly profound atrophy. Once you give contrast, there is nothing enhances. There is no evidence of mass effect. And this is another example of HIV encephalitis. There's fair amount of atrophy. There are bilateral confluent T2 hyperintensities along the periventricular white matter. This is 10 months later. It's fairly rapid progression. There is more prominence of the ventricular system with more confluent white matter abnormality in sort of bilateral, somewhat symmetric distribution. This is same patient on FLAIR. You have a better appreciation of the amount of profound atrophy as well as confluent white matter changes. This patient underwent craniotomy and biopsy, and this turned out to be all infiltration by HIV. So this was a case of HIV leukoencephalopathy. Note that there is no evidence of mass effect or enhancement. This post-contrast images here on the bottom shows no enhancement. How about this? This was more or less similar presentation. Patient was coming with neurocognitive decline in the setting of HIV. On pre-contrast T1 weighted images here on the left, a fair amount of atrophy. On FLAIR, there is these confluent white matter changes predominantly in the frontal area, internal capsule, as well as involvement of the splenium of corpus callosum. Note that this is different than the case of HIV encephalopathy that I showed you a little bit earlier. The white matter abnormality is there, but this time around is more asymmetric. It's not bilateral. It does involve the corpus callosum. And once you give contrast, this didn't enhance. And that basically segues to me to talk about another first opportunistic infection that I'm going to talk about, which is progressive multifocal leukoencephalopathy. It's a viral infection. It's latent reactivation of a virus that's a polyoma virus in setting of profound immune suppression. A PML was initially described in the setting of hematological malignancies back in 1958. In 1960s, the viral etiology was postulated, and in early 70s, the virus was isolated in a patient with hematological malignancy with the initials of JC virus. So thus the name of JC stays as the was given to the virus that causes PML. But now that we know that JC virus belongs to polyoma unenveloped DNA viruses, clinical manifestation is basically subacute decline in mental status. Dementia patients usually may have some degree of mutism, depending on which areas of the brain is affected. They may have variable degree of motor deficits or cerebellar changes such as ataxia. If it does involve the occipital region, the visual cortices, patient may have visual changes, and almost all the time, patient has fairly profound advanced disease or advanced immune suppression, generally with CD4 counts of less than 100. JC virus selectively infects the oligodendrogliocytes, and as a result, results in progressive demyelination. On histology, there's going to be profound myelin pallor with enlargement of the oligodendronuclei that are in decline, that are being infected by the JC virus, and the definitive diagnosis is made by biopsy, but CSF PCR is fairly sensitive to making that diagnosis. Before the advent of antiretroviral medication, it was universally fatal, but the mainstay of treatment is to start support the immune system. So there's going to be some immune system restoration. in the setting of HIV that involves giving administration of antiretroviral medications. On imaging, there is generally imaging manifestation of PML is asymmetric, confluent white matter changes that extends to the subcortical U fibers. Just remember, U fibers are these association subcortical white matter tracts that usually are the last ones that get myelinated. And in settings that there is this aggressive destruction of the oligodendrogliosides may involve the U fiber versus chronic small vessel ischemic changes that usually spares the U fibers. PML can involve the corpus callosum, but it doesn't necessarily need to involve the corpus callosum to suggest the imaging diagnosis. It can affect the white matters in the posterior fossa, and particularly cerebellum. It very rarely involves the deep gray structures. It tends to be multifocal, but it's usually asymmetric. There may be very, very mild mass effect, but mass effect may be modest, but it doesn't necessarily need to be present. Classically, it doesn't enhance, but if the disease caught early or in its more aggressive phase, there may be some peripheral enhancement along the edge of the areas of demyelination, and there may be corresponding diffusion abnormality. So this is a case of a patient with known HIV. We're seeing this confluent T2 hyperintensity in the frontal region extending to the corpus callosum that involves the contralateral side in a fairly asymmetric fashion. Post-contrast images, there was no evidence of enhancement, there was no evidence of mass effect on diffusion-weighted images. There was no areas of diffusion restriction, but we can sort of have a better appreciation of the extent of the disease correlating well with flare. Another case of PML, similar to the previous study that I showed you, more of a confluent asymmetric white matter hypodensities. Have a better appreciation on the extent of white matter changes on flare sequences. Note that there is very, very mild mass effect on the frontal horn of the right lateral ventricle. And following contrast, there is very, very mild enhancement along the edge of areas of signal abnormality in the left frontal lobe. A PAT specimen and corresponding pre-contrast T1 weighted image that shows diffuse loss of white matter or infiltration of white matter by PML, just basically fairly profound infiltration that has a sort of a fairly nice correlate with the previous cases that I showed you, as well as the MRI that was done months before. And this is a Loxel staining. Loxel basically stains the myelin, and in this PML specimen, there is fairly profound destruction of the myelin by destruction of the oligodendrocytes related to PML, as well as involvement of the U fibers and subcortical areas. On electromicrographs, the viral organism has been isolated. You can see this fairly profound infiltration of JC virus in this electron micrograph. When it comes to how to distinguish between PML and HIV encephalopathy, just to emphasize a few things that I went over, PML tends to be asymmetric. It can be focal, it can be confluent, versus HIV encephalopathy that tends to be more diffuse, confluent, and symmetric. PML involves the subcortical U fibers. Just remember, those are the association fibers along the cortices. HIV encephalopathy doesn't involve the subcortical U fibers. PML can involve cerebellum and posterior fossa. Just remember that there are large white matter tracts, peduncles in the posterior fossa that can be affected by PML. HIV encephalopathy classically does not involve the U fibers. Lesions may show some peripheral enhancement on PML or some areas of diffusion abnormality, versus HIV encephalopathy does not. Let's see if I know how to get rid of this. Involvement of the corpus callosum. PML may involve the corpus callosum, and HIV encephalopathy does not classically involve the corpus callosum. See? The other thing that I wanted to point out that there is somewhat increase in the incidence of the PML in the setting of immunosuppression in general. Any profound immunosuppression makes the host susceptible to PML. Recently, we have seen increase in immunosuppression in patients who, as the patients who have undergone hematological, bone marrow transplant in setting of hematological malignancies or general, lung or heart transplants, or patients who are being treated with monoclonal antibodies for collagen vascular diseases. Even a number of immune modulating medications may result in profound immune suppression and can make the host susceptible to PML and other opportunistic infections. I've listed some of the drugs that are used, fairly commonly for various autoimmune diseases, such as Tysabri for MS or Crohn's disease, Raptiva for psoriasis, rituximab. These are few medications to keep in mind that PML has been reported following administration of these medications. CellCept is another one to keep in mind. Now, I just wanted to basically segue here and talk about the immune reconstitution inflammatory syndrome. It's an inflammatory reaction that can happen weeks to months after initiation of antiretroviral medication. It has been reported in about 10 to 15% of the patients who receive antiretroviral treatment. It's basically a paradoxical effect. Antiretroviral medication attempt to restore the immune response, and they may sort of paradoxically worsen a pre-existing disease. It can be a sort of a challenging diagnosis, both clinically as well as on imaging, because the disease may seem to be worsened. And it's going to be important to keep in mind the immune reconstitution inflammatory syndrome in mind in the proper context, not to confuse that with relapse or recurrent disease. Because the last thing that you want to do is to sort of stop the antiretroviral medication. Just go to the next slide. It has been described in the setting of PML, also crypto and TB. As I said, it can be confusing. Sometimes there may be some atypical features. Patient may come with new enlarged lymph nodes. There may be both clinical and imaging progression. There may be some kind of an unusual changes, such as progression in mass effect or enhancement. And the treatment is to recognize immune reconstitution syndrome, continue the antiretroviral medication, and sort of provide more of a supportive measures. Administration of NSAIDs can be helpful, or corticosteroid can be helpful to sort of control the symptoms and keep the antiretroviral medications going. So this is a case of a patient with suspected PML. We're seeing this confluent white matter abnormality involving the right cerebral peduncle. Antiretroviral medication was started, and 4 weeks after antiretroviral medication, as you can see in the bottom panel, there's progression of this confluent white matter abnormality in the peduncle that extends into the cerebral hemisphere. And this was a case of immune reconstitution. A second example of the same thing. This is post-contrast coronal images that shows this non-enhancing hypodensity in the right cerebellum, in the peduncle, and after administration of antiretroviral medication, that area that didn't show any enhancement is enhancing now. We thought that this was immune reconstitution syndrome, and a few weeks later, on follow-up imaging, this finding stabilized. Another example of the same thing, this is pre-antiretroviral medication. On this flare, we're seeing this confluent white matter abnormality in subcortical distribution as well as involving the cerebellum. No associated mass effect or enhancement. After administration of HART, a few weeks later, patient was more symptomatic, had visual symptoms, and as you can see, there is significant progression of non-enhancing white matter abnormality with more confluent way, both involving the in posterior distribution as well as in the cerebellum, and some of this actually demonstrated areas of enhancement that wasn't present. And this was HART, and the medication was not discontinued. Antiretroviral medication was not discontinued. Patient received corticosteroids and has been doing well. Now, we're going to switch to the most common CNS opportunistic infection in setting of HIV, which is toxoplasmosis. Toxoplasmosis and an obligate intracellular protozoan. Antibodies are seen in about 50% of the population, with definitive host being cat. It's usually transmitted through fecal-oral transmission, poorly cooked meat, or through bodily secretions. Lesions in toxoplasmosis tend to be multiple, but at times we may also see solitary lesions. Typically, the lesions have this eccentric target enhancement or peripheral rim enhancement. Classically, they can be multiple. They involve deep gray areas such as basal ganglia, gangliocapsular region, thalami, or being a hematogenous process. You may also see it in the corticomedullary junction, as well as in the brainstem. Treated lesions may have some, at times you may see calcifications, and sometimes that may be related to treatment. And of course, the main dilemma is to differentiate that with lymphoma in the setting of HIV, which can have similar imaging manifestation. This is a case of a proven toxoplasmosis, non-contrast CT here on the left, demonstrates this large area of edema and hypodensity involving the left basal ganglia. There is also another area of decreased attenuation in the right periatrial white matter. On post-contrast images, there was this peripheral enhancing lesion in the left basal ganglia. On MRI, we can have a better appreciation of the morphology of enhancement. This has the sort of a rim enhancement, and in addition has this sort of a target-like enhancement within it. This is an eccentric target sign in the same patient, and you can also appreciate additional lesions that were present. So multiple nodular, ring-enhancing, target-like enhancing, bullseye enhancing that turned out to be toxoplasmosis. Another patient, another example of eccentric target sign here in the left subcortical region, and one in brainstem. Note that patient does have atrophy, and at the same time there is hydrocephalus with obstruction of the flow, dilatation of the temporal bone, and subependymal CSF spread. Different patient, classic rim-enhancing lesion, the basal ganglia, subcortical distribution. The signal intensity of these lesions can be variable on T2-weighted images. They generally do not exhibit the classic pattern of diffusion restriction that we see in pyogenic infection. Diffusion may not be, diffusion appearance may be variable. Rarely they show that type of diffusion restriction that we see in pyogenic infections, as I said. And the main differential diagnosis is CNS lymphoma. As you know, there has been a rise in incidence of primary CNS lymphoma since HIV. It is the most common intracranial neoplasm in patients with HIV, and prior infection with the Epstein-Barr virus may be a risk factor. It has overall incidence of about 5% or maybe slightly more than 5%. Lesions of lymphoma in HIV usually have an atypical appearance. They tend to be necrotic lesions with peripheral enhancement or ring enhancement. There may be more than one, there may be multiple lesions. Because of necrosis, there may be some areas of hemorrhage on susceptibility sequences. And the problem is that the imaging features of toxoplasmosis and lymphoma overlap pretty much often. As you can see in this case, there is this area of signal abnormality in this flare sequence involving the left thalamus, extends all the way to the brainstem. The peduncle is enlarged. Following contrast, there is this irregular rim enhancement associated with the main lesion in the midbrain. No diffusion restriction, and if you do perfusion, they tend to show very, very little or no abnormality in the CBVs. Another example, this is multiple necrotic rim enhancing lesions. One feature that can be seen in lymphoma is this profound involvement of the ependymal surface of the ventricle, as in this case demonstrates. There are large lesion, the degree of mass effect is there, but is somewhat dampened as compared to the size of the masses. And on diffusion weighted images, there may be some areas of diffusion restriction, but necrosis is a feature that doesn't restrict. And on gradient echo, there may be some areas of susceptibility related to microhemorrhages. Another case of biopsy-proven lymphoma on non-contrast CT, this fairly large right hemispheric mass. If you look at the attenuation, the mass is isodense for the most part with variable degree of vasogenic edema and hydrocephalus. Note that the cortical salsa has been completely effaced. There is dilatation of the temporal horns. Once you give contrast, this one sort of has some areas that maintain homogeneous enhancement. Note that there is bihemispheric involvement, but looking a little bit higher up, there are variable areas of necrosis associated with this lesion that turned out to be lymphoma. On T2 weighted images, there are some dark areas of signal on T2 weighted images that we expect for lymphoma, but there's a fair amount of necrosis that I demonstrated. In this case, it did exhibit areas of diffusion restriction, which sort of made us favor lymphoma more than toxoplasmosis. But a lot of times, that differentiation may be a little bit difficult. What is usually done is the patient, when it comes to distinguishing the difficulty in terms of distinguishing toxoplasmosis from lymphoma, both on imaging and on clinical grounds, patient may receive a short 6 weeks treatment with antitoxo medications, and they're closely followed and imaged to see whether they're responding to it or not. Now, this chart can basically summarize some of the features of CNS toxo versus CNS lymphoma. Toxoplasmosis is more common to be multifocal. When it comes to lymphoma, it's almost 50-50. Lesions in toxoplasmosis and lymphoma may involve basal ganglia. If there is something in the corticomedullary junction, I tend to sort of favor toxo more than lymphoma. Lymphoma tends to be involving the basal ganglia, but if I see something that involves the ependymal, subependymal region, or periventricular region, and corpus callosum, of course I favor CNS lymphoma versus toxo. Rim enhancement, both of them can have rim enhancement. If I see eccentric target sign or bullseye sign, that is suggestive of lymphoma. Sorry, that's suggestive of toxoplasmosis. If there's going to be some areas of increased attenuation on CT or T2 dark or diffusion restriction, I tend to favor lymphoma versus toxoplasmosis, but none of these rules are foolproof. On non-contrast CT, toxoplasmosis tends to be sort of more of a hypodense, sometimes may also be isodense. Nuclear medicine studies, especially thallium scan, is helpful in distinction, but sometimes this radiotracer may not be available, and the distinction may still be challenging depending on the size of the lesion. But classically, toxoplasma lesions are thallium cold versus CNS lymphomas tend to be sort of positive on thallium as well as PET scan. And as I mentioned, the treatment is different, but if it's not uncommon for patients to get a trial of pyrimethamine sulfadiazine, which is a treatment of choice for toxoplasmosis, and closely monitor them for response. And of course, lymphoma being a neoplasm may require chemo and radiation therapy, and ultimately, in a number of cases, histological correlation may be needed. Okay, now just to illustrate, this was a patient with HIV in setting of immunosuppression, presented with this is the imaging presentation that shows this enhancing lesion in the right thalamus, fair amount of vasogenic edema, regional mass effect. There was another enhancing lesion, left subcortical distribution. Patient was started in based on, we aren't quite sure whether this is toxo or a lymphoma, but patients started in on antitoxo regimen, and on 6 weeks follow-up, this lesion in the right thalamus has significantly shrunken, and diagnosis of toxoplasmosis was eventually established, and the patient had a good response to treatment. Now, cryptococcal is the most common fungal infection in setting of HIV. It's usually inhaled. The yeast, the spores are inhaled, and from there they get into the bloodstream, and hematogenous spread is common. Patient may present with subacute meningeal symptoms, headache, fever, nuchal rigidity, lymphophobia, and so on. And definitive diagnosis is usually established by CSF analysis. Just remember, India Inc. and antigen testing are very helpful in establishing the diagnosis. The imaging manifestation of the Cryptococcus is variable. A lot of times there may be very little imaging findings in cryptococcal meningitis in early disease. If the meningitis is florid, you can see the classic leptomeningeal enhancement. It may involve the basilar cistern and result in hydrocephalus. Another manifestations of Cryptococcus is this gelatinous pseudocyst appearance. The fungal material basically extend along the perivascular spaces, and they distend it, and they form this gelatinous pseudocyst that we classically see it, where the perivascular spaces are usually present along the anterior commissure and basal ganglia. Or there may be like frank abscesses of various size, being small microabscesses to sort of a larger abscesses, so-called cryptococcomas. And the abscesses may rupture into the ventricle and cause ventriculitis in rare cases in more advanced disease. I'll show you a few cases. This was a case of cryptococcal meningitis. As you can see, there is fairly profound thickening and enhancement along the cerebellar folia, compression of the fourth ventricle, mild early hydrocephalus that was going on. The disease manifestation was more apparent in the posterior fossa around the cerebellar folia. This is a case of gelatinous pseudocyst. As you can see, there is distension of the perivascular spaces along the anterior commissure. They're all distended. They don't show much of an enhancement. And Cryptococcus was isolated on CSF in this patient. Another case of gelatinous pseudocyst, as well as meningitis. As you can see, there is incomplete suppression of CSF signal along the cortical sulci, and there is distension of filling of the perivascular spaces by this sort of flare hyperintense areas that turned out to be related to cryptococcal infection. Note that there's not much of an enhancement of the gelatinous pseudocystis on post-contrast images. This is a pathologic correlate that shows distension of the perivascular spaces that are usually along the basal ganglia, along the anterior commissure, by this sort of tenacious, protinaceous fungal elements infiltrating the perivascular spaces, the so-called gelatinous pseudocyst. And just remember, India ink is a sort of a negative staining technique. Everything surrounding the area that you're evaluating picks up the stain except for the cryptococcus. So all these sort of cloud areas that are not picking up the stain are basically the spores of the fungal elements related to cryptococcus. Switching to CMV, it's another viral disease, opportunistic viral disease in the setting of profound immunosuppression that can be present in patients with HIV who have fairly profound dysfunction and reduction in their CD4 count. CD4 count are generally in double digits in the setting of HIV. It can also affect patients in other settings of immune suppression, such as in transplant patients. It's part of the herpes family of viruses. It's a herpes virus number 5. Antibody is seen in over 70% of the population, so it's basically reactivation of a latent virus. Now the imaging manifestation, we're going to go through it in a moment. Clinical symptoms are sort of fairly non-specific, depending on where the infection is. A patient may have variable degree of presentation. There may be non-focal. There may be some cranial nerve finding if it sits around the skull base. CMV retinitis if it involves the eye or retina. Patient may have meningeal symptoms if it involves the meninges, and it has seen in about 20% of AIDS patients in early autopsies in a series of studies. Now, imaging manifestation, again, is very, very non-specific. There may be imaging may be normal early in the disease, or some subtle meningeal abnormality may be present. But one thing that is suggestive of CMV infection is involvement of the ependymal, or the subtle ependymal lining and ependymal thickening, or signal changes around the ependymal is suggestive of CMV infection. And there may also be some non-specific white matter abnormality and atrophy, which is not specific in the setting of HIV. This was a case of biopsy-proven CMV infection. Asymmetric dilatation of the ventricle on its own is non-specific, but there was this subtle irregular ependymal enhancement along the lateral ventricles. This is an old case. This is a proton density that better depicts this ependymal hyperintensity. There's corresponding images on FLAIR demonstrates the same thing. Looking at it on a different plane, we can sort of better appreciate the enhancement along the ependyma, in this case of CMV ependymitis. And this is a proton density again that shows abnormal signal along the ventricles, as well as this sort of uniform hyperintensity along the ependymal margins of the ventricle. And on autopsy, there's this CMV infiltrating along the ependyma and also extending into the ventricular system here and involving both frontal horns. Now, there has been resurgence of TB in the setting of HIV and immunosuppression. 15% of all TB mortalities globally are related to HIV infection itself. It can be result of hematogenous spread from lung infection, but it can, but in few cases the lung findings may not be there. Again, the lesions tend to be multiple, and imaging manifestations varies from TB meningitis. Typically, TB causes this thick exudative enhanced involvement of the basilar cisterns. Patient may come with variable degree of cranial neuropathy and meningeal signs related to it. Invariably, hydrocephalus may be present. And as the disease infiltrates along the subarachnoid space and basilar cisterns, there may be some kind of a reactive arterial infection, inflammation, and vasospasm, and patient may present with small deep gray nuclei infarction as one of the presentations. TB abscesses can also be present. These may be intra or extraaxial abscesses. Extraaxial related to TB infection can mimic variable degree of extraaxial lesions, and there may also be gross abscesses or tuberculomas that tend to be multiple. This was a case of TB meningitis, and this first presentation. Note that there is absence of CSF attenuation involving the basilar system. That is all filled by TB meningitis here, and note that there is hydrocephalus with dilatation of the ventricular system. Temporal horns are up and cortical salts are effaced. The same patient on FLAIR sequence, we have a better appreciation of signal alteration along the basal cisterns, signal abnormality along the interpeduncular cistern surrounding the midbrain, as well as abnormal signal along the lower portion of the sylvian cisterns. On post-contrast images, there is this thick abnormal enhancement predominantly at the level of the basilar cistern surrounding all the elements of the circle of Willis. And of course, this patient must have had some cranial nerve symptoms as well. A different case that shows these not only basilar meningitis, but also these microabscesses along the fourth ventricle, and all these small abscesses and extensive inflammatory changes and meningitis along the vessels of circle of Willis, MCA vessels on both sides. There is corresponding flare hyperintensity, and a different case that shows this tuberculomas and abscesses more or less again around the basilar cisterns and cranial fossa here. This is more of a late complication of TB meningitis. These focal infarction along the deep gray nuclei because of involvement of the basilar cistern and perforated arteries. Now quickly talking about arteriopathy. Unusual arteriopathy can happen in the setting of HIV, and HIV-related vasculitis has been reported. Hypothesis is that that's the repeated infection can result in inflammation in subarachnoid space and can involve the vessel walls, and over time medium to small vessels may be affected. And the imaging manifestation would be this sort of like a very, very unusual, peculiar arteriopathy in the setting of HIV that may vary from areas of ectasio-aneurysmal dilatation to areas of stenosis and beaded irregularities of multiple vessels of circle of Willis, as this case is demonstrating. This type of complication related to HIV is fairly rare, but it can be very dramatic, as this other case shows marked irregularity involving the basilar artery. There is this aneurysmal irregularity of the basilar tip going into the posterior cerebral arteries, as well as areas of irregularity, dilatation, and arteriopathy involving the anterior circulation as well in this case. Now, quickly, a note on pediatric HIV before we conclude, it usually results from vertical transmission, maternal transmission in children. Once that vertical transmission occurs, about 20% will develop AIDS by age 1, and 70% may be seen by age 5. Clinical manifestation is sort of unusual. You know, children may lose some of expected normal developmental landmarks and failure to drive. As compared to adults, the opportunistic infection tends to be slightly less due to lack of exposure. So they don't have that many viruses. They have not exposed to so many viruses to have resurgence of the viruses in the setting of immunosuppression. The imaging manifestations, again, is just rapid atrophy, infection of the HIV itself, infecting the brain. A patient may have premature basal ganglion calcifications or white matter lesions. The CNS lymphoma is the most common mass lesion in setting of pediatric HIV, and a patient may have variable degree of cerebrovascular complications. This is an old case of pediatric HIV that shows atrophy in a short period of time and abnormal premature calcification of the basal ganglia symmetrically. This is another case that shows sort of unusual mineralization of basal ganglia for patient's age. So just to summarize, neurological complications of HIV are common. We went over a few of them. We went over how to distinguish some of the imaging features of HIV encephalopathy itself versus PML. Remember, the toxoplasmosis is the most common infectious opportunistic infection in the pediatric AIDS, and we looked at some of the ways to distinguish or help us distinguish between toxoplasmosis or lymphoma. Sometimes it may not be so straightforward. They may require some kind of an empiric treatment for a short period of time. And we also discussed a few other opportunistic infections such as crypto and CMV. And I want to thank you for your attention, and thank you again for listening. And if there's any questions, more than happy to entertain.
Thanks much, Dr. Hassankhani, for the incredible presentation and great collection of images. Let's proceed with the question. If there is any question, we would be happy to take those in the Q&A chat box. So there is a question from, apologies if I'm not spelling it correctly, Janendra Kumar Bhagat. Infection imaging by FDG PET CT can differentiate accurate and treated or recovered cases. It was a comment, I think. What do you think about it, Dr. Hassankhani?
Well, you know, FDG PET for infectious etiologies, I'm not quite sure what the utility of it would be. But when it comes to toxoplasmosis versus lymphoma, in setting of in settings that the distinction can be somewhat confusing, it can be helpful. Again, it depends on the size of the lesion and so on, but it's not foolproof. But lymphoma tends to have subtle increases in FDG as versus toxo. But because of the necrosis and all that, that may not be that may not always hold true. It certainly is not a gold standard. Let's put it that way.
I understand. And I have one question. What do you think is like the best modality or sequence to diagnose lymphomas, or differentiating them from toxoplasmosis? I mean, if you have to choose like one sequence or modality.
Well, you know, there is a lot of overlap. You know, I sort of don't rely completely on one sequence versus the other, but a number of imaging features acquired from different sequences would be helpful. For instance, if there's going to be, you know, for instance, at times, you know, perfusion can be helpful. You know, lymphoma versus toxo, they can have some role, but the pattern would be helpful more than a particular sequence. For instance, if there's going to be involvement of the corpus callosum, it's going to make it a little bit easier to sort of think that may be lymphoma versus toxoplasmosis. Diffusion, for instance, if the lesion has some areas of solid components, ADC maps can be helpful. But as I said, there is no silver bullet alone. You have to sort of look at the entirety of the imaging sequences, and also the clinical information would be very, very helpful. For instance, does the patient has antigens to toxoplasmosis? What is the CSF is showing? So I cannot name a single sequence that can be the sequence to go to.
I understand, yeah. And also there's the question from Zerihun Galashe asking toxoplasmosis versus TB, how to differentiate them?
Well, TB can have variable degree of manifestations. I guess presentation of toxo and TB can be a little bit different at times. TB, may present with sort of a profound basilar meningitis, as some of the cases that I showed you. I think toxoplasmosis may show more of a rim-enhancing lesions. Toxoplasmosis may involve the basal ganglia. TB may have like this tuberculoma abscesses and so on. And ultimately, I think correlation with CSF would be key to make the distinction. In all honesty, I guess the classic differentiation, the classic dilemma in imaging would be toxoplasmosis versus lymphoma, not so much toxoplasmosis versus TB.
Yeah, I understand. If there's any question from the audience, we would be more than happy to have it in the Q&A chat box. We have a question from Anissa Afram. Sorry if I'm not pronouncing correctly. Please go ahead.
You must be mute. I cannot hear you. I'm sorry.
Yeah, I think it's on mute. Anissa, can you unmute or type your question in the Q&A chat box, either or? Also, Dilip Kumar Patel has raised hand. Dilip Kumar, can you type your question in the Q&A chat box? Okay. All right. If there's no more questions, I want to thank you, Dr. Hassankhani, for joining us today. I just want to let you know that all Health for the World lectures are freely available on our YouTube channel and our website. And wish you all a great weekend ahead.
Thank you.
Thanks much. Have a great one.